We all share that common goal of helping parents become informed and organized as they make decisions for and with their young adults. And we covering any kind of transition planning and adult services. So we thank SCDD for this presentation tonight. I'm really looking forward to hearing what David is doing with in the mental health world. And let's jump right in. Thanks, David.
Thank you, Lisa. We're very excited to be a supporter of Connections California. It's Parents Helping Parents is one of the stronger family resource centers throughout the state of California, reaching out to all Californians and having these presentations available and then the recordings added to their e-library. So thank you, PHP, for doing that. I have two more introductions to make. I want to introduce Sheridan Nicolau, who is my counterpart with State Council on Developmental Disability. She's the regional manager of the Bay Area office, covering the Marin County, San Francisco County, San Mateo, Alameda, and Contra Costa counties. So she's here to facilitate the meeting and manage questions. We have the opportunity to ask questions via chat using the Q&A button on your toolbar to type a question in, or raising your hand, and Sheridan will acknowledge that your hand is raised, allow you to speak upon your recognition. Our goal tonight is to get into a conversation. This is a complicated topic. It's behavioral health. Every person's particular behavioral health needs is different than the other person. So rather than doing a overly broad, overly systematic presentation, I don't mind having conversations that maybe are helpful to the family system to improve the overall care for the person with the developmental disability. And then my last introduction, but my most important, I'd like to introduce Darcy McCann. Hello, Darcy. Darcy receives services from the San Andreas Regional Center. She and I are colleagues. Darcy is very involved in behavioral health. She's a student getting her PhD, and I'll let her describe the program she's attending. She's a mentor to other people with developmental disabilities, and she is has been for several years a volunteer with crisis hotline, suicide hotlines, and she's soon to be, and from my point of view, currently a fantastic clinician, and I'm happy to have her here tonight. Darcy, say hello to everyone.
Good evening, everyone. Thanks for allowing me to be part of this great topic.
And then Darcy, which university are you going to? I always forget.
Yeah, I'm attending Fielding Graduate University in Santa Barbara. It's an online program. It's a one-year post-bac program to help me get into a clinical psychology program. And then after that, I hope to specialize with children and families with developmental disabilities.
Fantastic. So as we get started, I'd like to talk a little bit about some of the terminology. Our culture is interesting. Culture is interesting in that language adapts to how we begin to perceive things. And as we become more sophisticated in our perception of behavioral health or mental illness and of developmental disability, we're going to see shifts in language. So a couple of things. In the past, the term dual diagnosis and mental illness were the primary terms utilized to describe people with developmental disabilities who had mental health issues or mental illness issues. That language is a little bit focused, too much so, on illness and on deficits. So as our culture adapts and moves forward, you're going to start seeing the term co-occurrence, and we're going to move it from mental illness to behavioral health needs. So as advocates here at this meeting tonight, I encourage you to adopt this language. It's always important to educate and build awareness by the language we use. But I also want to point out that this language does remain inexact. Co-occurrence can be confused with substance abuse,
And behavioral health, particularly for people with autism, can be confused with ABA. So as you build your thoughts around behavioral health and intellectual and developmental disabilities, be sure to kind of use language in the way and clarify as you speak with others. So I'm going to start off so today's intention is I'm going to start off giving some general information. I'm going to talk about how to navigate the service systems between developmental services that are provided by the regional centers and by behavioral health services, which is provided by primarily by private healthcare, your private healthcare company or insurer, or the counties, or county services. After that overview, we'll talk a little bit about behavioral health, things to look for people who have developmental disabilities, intervention strategies around anxiety and trauma, and then end our presentation with a discussion about wellness. So our general information is there's a lot of uncertainty still about the rates of people who have developmental disability and co-occurring behavioral health needs. The range is, you can see that first statistic, it goes from 14% all the way up to 70%. The National Association for Dual Diagnosis has kind of focused it into between 30 and 40%. But there is probably a cause for this uncertainty. When you think about it, if you are just collecting data with a specific diagnosis of psychosis or mental illness or mental health, that would maybe limit it. But when you add other types of behavioral health needs, particularly trauma, anxiety, and depression, you're going to see that number go a little higher. The statistics here are from CEDAR. This is a document that the Department of Developmental Services put together, and they do keep data on behavioral health needs and diagnosis of people with developmental disability. And from the point of view of the Department of Developmental Services, from the point of view of the regional center, the statistics indicate that rate of behavioral health needs is about 11% of the total population of people with developmental disabilities. But again, if you add anxiety, depression, and trauma, that rate's going to go way up. Darcy, do you kind of feel that's true as well? Do you find anxiety and trauma and depression some of the issues faced by our community?
Yes, I think that it really depends, but I think often these numbers tend to be kind of underreported sometimes, especially for people with disabilities.
Great. So if the people here in tonight's webinar have been trying to access the behavioral health services, you're probably discovering that it's very complicated. There are two difficult systems to navigate through, and there's quite a gap between developmental services and behavioral services. The tendency is that if a person with a developmental disability who is experiencing a behavioral health need and requires the care of a clinician through either county behavioral health or their private insurance company, once those clinicians or administrators find out that the person has a case open with the regional center, or the person has been diagnosed with a developmental disability, they're going to say, oh, you need to receive services from the regional center. So what they'll do, it's like a hot potato. They'll throw the case back to the regional center, and then the regional center is to provide with the assumption that the regional center will provide the therapeutic intervention. This may have been the case 20 to 40 years ago, but it is less and less so now. Regional centers, of course, are to attend to the developmental needs of our community. They don't truly have therapeutic intervention services. Quite honestly, that's considered a generic resource, and the generic resource is to be the organization or the system that is to provide that clinical care. So what tends to happen then in these circumstances is that as an individual with the developmental disability is contending with a behavioral health crisis, no one is arranging or offering services that's going to support them. It's particularly problematic in crisis situations, and we'll talk a little bit more about that now. Now, for people with developmental disability, just as anyone in the community, they are to receive behavioral health services either through their private insurer or through the county if they have Medicaid or Medicare. And those services are somewhat similar to what is offered in the developmental system, but also quite different. Now, for developmental services, of course, if a person, when a person is going through behavioral health needs, where they reside is very important. And so on the left-hand side of the slide, you'll see the series of residential arrangements that may or may not be available to people with developmental disability. And then there is some minor service supports for crisis intervention on the developmental side. That includes California START services, which provides intervention with the support system on how to better care for the individual with the disability. There is a crisis intervention team, and then there are a type of residential arrangement called Star Homes that are available. And there are still a couple of developmental centers that are still in operation, particularly to treat the needs of people who are going through mental health, having mental health issues. This is but generally, regional center systems rely on generic services. On the generic side, there are housing opportunities through IHSS. Many of you may be familiar with IHSS. There are actually residential care homes for people who have behavioral health needs. Treatment is usually offered through behavioral health contractors. These contractors on occasion run transitional housing where the person goes from crisis into stable housing and receives therapeutic intervention in those transitional situations. And then they do receive clinical care. For crises, a 911 call can lead to emergency hospitalization, 5150 holds, which are up to 48 hours or maybe up to 72 hours. There may be transitional housing, and there may be follow-through stabilization. Both of these systems, both the developmental service system and the behavioral health system, are extremely limited in capacity. There is not enough housing to treat the needs of people with behavioral health needs, and there are not enough clinicians or clinical support. So we are really faced not only with two systems that aren't working very well together, we are also faced with the capacity issue. And at this point, if anybody has any questions, I'm happy to answer them, or please feel free to speak up. And Sheridan, I'll let you call on anybody who does raise their hand.
We're all good so far. Thank you.
All righty. along with this issue of two separate systems that need navigation, that a family would need to navigate through, there are tremendous gaps in how to, in getting services delivered. This, I call this a wheel, a behavioral health needs wheel, and it identifies 8 areas where behavioral health intervention is needs improvement, and we need to create policy to enable better treatment of people with co-occurring needs. Darcy is an example of her going to school about workforce development and training. Darcy, at your school in Santa Barbara, do they do any instruction regarding developmental disability?
No, in fact, I talked to the dean of the program last week, and she said, well, I think that's an area that you're going to be really passionate about and able to educate us further about how we can include people with disabilities, not only in our curriculum, but how to interact with people with various disabilities. So she was very positive after approaching this several times. So I think if I could just continue to have these conversations with other universities, hopefully that will also help people navigate this system, because she had no idea. Even as a clinician, she's been a clinician for 30 years and she's never worked with anybody with IDD.
She may have very well worked with people with IDD, but just didn't recognize it, particularly
Yes.
with autism. As the diagnosis of autism is increasing, I have a
Right.
feeling that there's a lot of people who receive therapy who have autism and receive treatment. And Jody, I do see that the slide is difficult to read. I'm sorry about that. We will be sharing the slides with PHP, and we will make them available to those who've attended tonight's program. And I think when I send that out, I will send the Word version of this slide so that you can have a better ability to reach it. Other things so workforce development is huge. As Darcy's saying, at the schools, the Board of Behavioral Sciences, it's not a requirement to teach or to give instructions about intellectual and developmental disability. And again, it's based on that old idea that if you have a person with an intellectual and developmental disability, that person is to be and receive supports and services from on the developmental side from the regional centers. We continue to go around the wheel. Assessment and evaluation is there are, if you're to do a screening, a mental health screening, there's no questions about IDD. So if there's no questions to ask, there's no way you can be accurately evaluated. Clinicians are not given instruction, and we're way behind on research on the most appropriate means to treat and provide intervention for people with developmental disabilities who are going through behavioral health needs. It becomes particularly difficult when therapies are generally talking therapies and there's communication needs among people with developmental disability, that a clinician doesn't quite know how to provide treatment. However, there are a tremendous number of examples where alternative means of communication or alternative means of therapy can lead to positive results, and we'll talk a little bit more about that. Everyone is a little worried about law enforcement and first responders' response to situations where a person with a developmental disability reaches an emergency situation where there is a crisis and law enforcement needs to be called. Of course, we're worried about how law enforcement will interact with that individual, and are they intervening at a way that's not going to be more traumatic or more damaging, and are they going to assure the safety of the individual when they're being evaluated. That's on one end of the spectrum. On the other end of the spectrum is that law enforcement, once they hear the person with a developmental disability has a case open at regional center, may decide not to intervene at all and turn it back over to the family and have the family call the service coordinator and have the service coordinator be kind of caught in between saying, how can I arrange emergency services when it's not something that the regional centers are able to provide? So we have a whole range of how law enforcement may need to respond. And this again requires education, training, and awareness building among law enforcement. 5150s or inpatient or emergency room admissions is complicated. 5150 is designed to protect a person who may be in danger to themselves or others. It's a 48-hour hold where they are able to kind of calm down and stabilize and get out of their crisis situation or the psychosis that they're going through, to have some sort of intervention or psychiatric care at that time. However, these 5150s, the minimum standard to create these hold situations do not include any arrangement for people with intellectual and developmental disabilities. So that person is put into an unfamiliar situation around other people, and there's a high risk of vulnerability when a person with a developmental disability is placed in a 5150. So again, there's real concern about that. Many of us may already know about the housing shortages for people with developmental disability who are just wanting to move into the community. But when there's a behavioral health need and there's a need for a wide range of supports, both behavioral and developmental, there's even fewer housing opportunities. And there's fewer direct service professionals who know how to care for these folks. So it becomes very complicated. Of course, to make all this work, the requirement is to have policy match what's needed. And so this requires legislators at the state level, our California representatives, to be aware of this issue and to start designing policies that can serve both people with intellectual and developmental disabilities with co-occurring behavioral health needs. That requires the integration of two systems, the developmental system and the mental health system. So service integration among large departments doesn't occur as frequently as it should or as smoothly as we would expect it to. So there is a need for service integration as well. I see a question.
Oh, great.
Yeah, could you read the one in chat?
Yes. KS is asking, would you let us know the names of colleges in Santa Clara in California that are supportive for people with IDD?
Well, that's a great question. So,
and it depends
Darcy,
on what is supportive, right?
Yeah.
Yeah.
Darcy, I'll let you answer. Maybe you can give an insight into your college experience.
Okay. It really depends on, I'm assuming you're asking related to people with IDD/mental health. It really depends on the program or the school. I mean, I believe that all schools should have some sort of supports and places where a student could go. However, navigating that system can be very, very hard. I mean, I would first say to go contact the disability services at that university and see what they can offer. Often that it leads to a whole bunch of different services that the person could get. I'm not sure in regards to like mental health services at a university, they're, I think, becoming a little bit more user friendly for people with disabilities. It really depends on the school and where you go.
Thanks,
But
Darcy.
I would say start advocating sooner than later, depending on where you're going to try to go to school. Even at the community college level, there's some great supports out there.
Yeah. So I would say the good news is that universities and colleges are becoming more aware of the needs of people with developmental disabilities and beginning to open their doors toward allowing them to apply and become students at the universities. But Darcy's right. The IDEA no longer applies at the university level. So special education services is not something you can get in community college. The prevailing law for community college or for colleges would be the ADA, where the accommodations need to be made. And Darcy's correct. You would find out about the necessary accommodations through the Disability Services Department at that college or university. Now, community colleges are really good about creating opportunities for students with developmental disabilities. So you might want to do some research and find out what's available. And then there are universities that have a greater awareness about students with autism, maybe type 1, level 1 autism that would qualify for the entry criteria for a university. And they're becoming stronger and stronger with the awareness. Oftentimes, though, the supports available through disability services are not as robust as needed for the student to succeed. In such cases, there are actually independent living support programs that are vendored through the regional center that could provide ILS services for the student on the campus. There are some great model programs going on, and there's currently a model program going on at University of California at Davis, where 15 students with IDD are going to school and living in the dorms and having a full college experience. However, it's just 15 students. It's a very that's a more difficult eligibility requirement than getting into Stanford. So, but there is legislation kind of making its way through the legislature to have programs like this model program at UC Davis be available on every university and college campus in California. That's a few years down the road, but it's exciting.
It's AB 2920 for those that are interested. It's a bill that's currently working its way through the legislature. The state council is a co-sponsor, and this bill, AB 2920, provides students with a person-centered planning process and the opportunity to pursue an educational credential in alignment with kind of a Think College model standards. Think College is a well-known model. So specifically, it would give about $8 million each year to create 8 inclusive college programs for students with intellectual and developmental disabilities at 8 public 4-year universities. And it would give another $2 million to establish a California UC/CSU coordinating center for inclusive college education. And then one of the fun facts circulating with this bill is that there are currently 66,000 California transition age students with IDD that are just waiting for college opportunities like this. And our long-term goal is to have quality programs at all 32 CSUs and UC campuses in California. So I'll pop that bill information.
Yeah, that's exciting. It's a very exciting news. So lots going on, but still a long way off would be the answer. Christine, your question that I see in chat is what happens if a client in an adult residential facility that's funded, that is part of the regional center system, part of regional centers receiving funding through regional center services, is going through a crisis. And so, Chrissy, that leads to this slide into what we need to talk about next, is how do you navigate the gap? And this is, so the answer to your question, Christy, is it Christine? Let me go back up a little. It's Christine, I believe. Yeah, yes, Christine, the answer to your question is complicated. So a small, short question, long answer. If the person is in crisis, as you mentioned, then the ARF is to call 911 and to request emergency services. Currently, the standard is law enforcement will go out and be there to try to calm the situation down. However, there is a lot going on in terms of crisis intervention teams that are more therapeutically minded, that are not that do not include law enforcement officers. Each law enforcement region is adopting these new programs, and it would be ideal if a crisis intervention team could come out and do an assessment. It's at that intervention at the when the crisis team or the law enforcement comes out that the determination is made, is the person a danger to himself or a danger to others. If that criteria is met, then they are to be either considered for hospitalization and and go to the emergency room, or considered for a 5150. But Christine, what you may know or may have encountered, or what we're talking about already, is that, again, law enforcement doesn't know how to properly respond. They may turn this back over to regional center, or the emergency admissions may turn it back over to regional center, or the people at the 5150 hold may turn it back to regional center. And in that case, the regional centers really aren't prepared to handle the crisis as effectively as the county system as the county system. So that's where that hot potato situation comes in.
David, can I make a comment?
Sure, go ahead.
So sometimes with someone being in crisis, it depends really on the crisis. If it's an immediate type of situation, yeah, of course, law enforcement or calling 911 could be the best, but there are like crisis centers that could also talk with somebody through the situation as well, depending on how severe it is. So I find, I've done suicide crisis for over 16 years. I find that if I can talk with somebody, I can often de-escalate the situation to the point that maybe the police are not actively involved in the situation. Now, if the person is really in crisis, then that situation needs to take place. So it really depends on the level of crisis. And as David was saying, I really think that people are becoming more sensitive to all needs of people with disabilities. I know at my time as a crisis counselor, I talked to several people with disabilities. And when I mentioned, have you talked to your service coordinator about what you're experiencing? No, I haven't. Should I call them? Yes, you should call them, reach out for support. I mean,
thank you. Yeah, Darcy, that's a great answer. So Darcy's spot on, and she talked about the term de-escalation, and that's important. And we'll talk a little bit about de-escalation in tonight's presentation. But a good thing is that reach out to, so the best way to handle de-escalation is to avoid the escalation. So as soon as you start seeing any cues that might indicate that the person is in a situation that could get worse, as soon as that happens, a call to your service coordinator would be helpful. And then what you would request from your service coordinator is, I think it's time that we get your vendorized crisis intervention team here to provide some intervention. And these crisis intervention, there's one at San Andreas that's managed by an organization called CIWP, and they do either in person, or I think through the pandemic it's been by phone, some crisis, some de-escalation techniques to kind of help the situation become less problematic and avoid it from becoming more severe. You're also going to want to ask your service coordinator to look into California START services. I mentioned this a little earlier. These are new services that are being made available throughout the state and is available for California, for clients of Regional Center East Bay, for San Andreas Regional Center, and a few programs in Southern California. I know that there's a START service program in San Diego, and there are some opening up in the Central Valley, those sorts of things. START services will begin working with the individual and the support team to come up with strategies to help avoid crises from occurring and come up with strategies to avoid the need to call 911 in these sorts of situations. So I get a long answer to a short question. I hope that was helpful.
And David, can I
talk about 988, Sheridan.
Yeah. So a lot of people I find don't know about 988. So back in 2019, the FCC worked with the U.S. Department of Health and Human Services, as well as Substance Abuse and Mental Health Services, Veterans Affairs, several other councils and committees. And we passed, they were all able to pass 988, which means that starting this summer, I think July 16th, 2022, anybody in the country, all states, can dial 988 for mental health emergencies or crisis emergencies. And that will direct people instantly to the nearest suicide prevention lifeline, where they can also get access to local county mental health care supports. So there's a lot of work that's being done to be ready for this summer's rollout. But that's an exciting development to know that 988, instead of 911, will be available for people that need mental health, behavioral health care, emergency services, but don't necessarily want law enforcement out, or want to make sure that if law enforcement come out, that they come out with mental health care professionals that are skilled in crisis management. So that's an exciting development that's should be rolling out this summer.
Thank you, Sheridan. But yeah, this is a key time in the mental health services, based on what we all know is happening in our world today. And one of the goals of today's presentation, and just in general, is to, as we think about the behavioral health, we also be sure to remember people with intellectual and developmental disabilities should be included, and there should be an awareness level that they are entitled to these same services that that all people are going to be should be able to receive. So when wrapping your head around behavioral health, the best way to think of it is it goes from wellness, which is, you know, that place of where we're feeling good both physically and mentally. But then as we move up, we want to be focus on prevention next, ways to avoid the situation of a person having a psychosis or a behavioral health crisis. If the person does need care and treatment, we want to go into intervention and treatment strategies. And then the worst case scenarios are those psychoses or those events that would be crisis, where the person is in danger to themselves or to others. And as I've been pointing out throughout today's presentation, the developmental system through Regional Center handles it a little differently than the behavioral health system. And so here you see that the crisis here you can see that in this outline that I provided, that there is California START services, there's the Regional Center Crisis Intervention Team, but CalSTART can be approached before they're at a crisis level. And you can maybe request clinical counseling if the Regional Center has a vendored counseling program. Now, as we build awareness within the county behavioral health care systems, we're hoping that they can begin providing better care and treatment for people with developmental disabilities. And oftentimes they have a more robust series of interventions and treatments. There are, at the prevention level, particularly at in most counties, but also in Santa Clara County Behavioral Health, they have family and youth services where the intervention can begin while the kid is a student in high school and is beginning to demonstrate some issues that might lead to behavioral health needs in the future. In the behavioral health side, there are nonprofit behavioral health contractors in Santa Clara County. You may have heard of Momentum Services or Community Solutions. These are Santa Clara County behavioral health contractors, and they work with people who've been referred to them by the county for treatment. Lots of interns from the programs that Darcy's been speaking about work at these organizations. So there's an effort to get these interns educated on how to treat people with developmental disabilities. Of course, there may be a need for psychiatric intervention, which of course would include psychotropic medications. And then Again, if the person is in a situation where health and safety are at risk, we want these services to be more enhanced. Now, there is greater dialogue between Santa Clara County Behavioral Health and San Andreas Regional Center, so that when these services need to go back and forth, or when behavioral health needs to be involved, they have a better understanding of how to respond. What we need to have happen as advocates is that these interventionists do not automatically refer cases back to regional center and consider that the appropriate intervention technique. They are obligated to provide care and treatment for all the citizens of the county, and therefore need to work with people with developmental disabilities. Any questions about this? So I guess the answer to this question is navigating the gap. As you navigate the gap, as you're doing your best to navigate the gap, you're going to run into issues that are going to most likely be very frustrating. Presently, I would not give this service system for people with developmental disabilities coping with behavioral health needs a high mark. There's a long way for them to go to meet the needs of our community. Any questions at this point? Darcy, what are your thoughts about that?
So, like, I think, like you were saying, like with the regional center and other partners, it's often like I worked often at Santa Clara County Suicide and Crisis on the weekends. So I could not refer to the regional center, or I could say, you know, contact your service coordinator on Monday. But if there was an immediate need, I mean, I did a couple face-to-face interventions, and like I remember one example, the person was very, very much in crisis. And then after talking to them about 30 minutes or so, the clinical team was like, Darcy, what do you think? And I said, you know, I think that they just need to be heard and be able to be listened to. And of course, the situation de-escalated, and I recommended, you know, follow-up care. But I think in the moment, a lot of clinicians are really afraid of working with people with IDD. So if you could break it down and say, you know, so-and-so might be displaying these symptoms, but this may be normal for them. But if they're brought into a hospital setting, of course they're going to escalate. So it just depends on the situation. But I think more education for not only the community, but mental health providers definitely needs to take place.
Absolutely. And families and
Yes.
the individual and the family. And it's one of the reasons for tonight's presentation. As family members, we want you to have an awareness of this so that you can kind of say, what's best for my child at this point, or for the individual, what's best for me at this point? And we'll go more into that as we proceed. So if you think about it, when navigating the gap, ideally, we want the service system to meet all the needs. We want developmental services to be involved where developmental services are needed. And we want behavioral health to be involved where behavioral health services are needed. So this is an example of the work that's being done to try to move these things forward. So again, getting care through the regional center, you have these choices. And then getting care through generic resources include your private health insurance company or your county behavioral health services. Kaiser is, of course, a private healthcare company, and just for their general membership, have received criticism for the behavioral health care they operate. They too need to build a level of awareness for therapeutic intervention for their patients who have IDD. So there's really not one ideal organization to manage all this, but we want to kind of have a universal improvement both in the regional center systems and the generic systems. All right, any questions as we move on?
No hands or questions so far. Thank you.
Great. So there is a team of advocates. State Council both Sheridan and I, State Council Central Coast, facilitates and leads an organization called, or not an organization, a community group called Bridging the Gap. And we are very active in trying to address these gaps in services. So we've talked a little bit about the START community and its outreach to train clinicians. The same is happening with State Council. I'm going to try to work with Darcy to see if we can get a workshop at her university to train the students getting educated about IDD. There is some assessment and evaluations improving going on at the Santa Clara County Behavioral Health. The team that works with people who've been arrested and are maybe encountering jail services have added a question about autism and intellectual disabilities on their assessments. Something that simple has just been added within the last year. Treatment and intervention. We want to update and include treatment protocols at Santa Clara County Behavioral Health based on evidence practices. I also want to point out that there is a vendored clinical service at Regional Center at San Andreas, Hope Services. So if your child does need therapy, you can receive clinical services at Hope Services. And this is most likely true for most regional centers. There are clinical service programs. So you would want to ask your service coordinator if they do have clinical services and how can my child qualify for those clinical services. Sheridan, you're over on the East Bay, and Alameda County has the Schreiber Center. Is that correct?
Yes, yes. And it brings up a good point, David, which is depending on the county and the area that you're in, there may or may not be restrictions in terms of to be eligible, people might need to qualify under the specialty mental health care eligibility. So just emphasizing what David shared is ask about eligibility, because not every program will be accepting folks with or without diagnoses, with or without moderate or severe characteristics. So that's just something to keep in mind.
Yeah, great point. So because of the capacity issues, the good rule of thumb to go is, since there's not enough services available, the services that are available are going to be for those who have the greatest need. So when you have that conversation with your service coordinator at Regional Center, the service coordinator might say they don't match the eligibility requirement because their need is not as great as it should be. So that's an unfortunate answer, but it's how that you have to administer services when we have such limited capacity. Okay. So we're going to shift now more into what are we shifting into? We're shifting now more into treatment and intervention. So the first thing I want to point out is from a medical point of view, or from a psychiatric point of view, or from a psychological point of view, from a regional center point of view, from a state of California point of view, they divide the understanding of behavioral health, of cognitive needs or affective needs, into the developmental needs versus the behavioral health needs. So developmental, which is what the regional center funds, services to support people with developmental disability, is a very different standard than the behavioral health disorders, which would be those issues affecting your mood, your thinking, and your behavior. And the examples of these are eating disorders, psychoses, substance abuse, trauma, personality disorders, anxiety, sleep disorders, obsessive compulsive disorders, depression, bipolar, and dissociative disorders. That's a very different list of needs than people with developmental disabilities who may have cognitive impairments, difficulty socializing, and difficulty with communication, and difficulties with the activities of daily living. So The reason there's this split is because as legislation and as policy has been made, they've divided the policy between developmental and behavioral health disorders. And what we need to see start happening is the integration of these two systems. Darcy, do you have experiences where you've run into this complexity between behavioral and developmental needs?
Yes, it's sometimes because they can be overlapping often. So I mean, I talked to someone in particular and they said, I have autism, but I also have generalized anxiety, and I'm also really, really struggling with my mood. So where do I go for support? Because I feel like it's not just mental health, but I'm not getting what I need from the regional center as well. So
Exactly.
it was very difficult for this person to navigate.
Definitely difficult. And as an advocate for your child, or as an individual with as a self-advocate, as a person with a disability, it's important when you're speaking with your service coordinator to try to speak in this language between developmental and behavioral, saying, yes, I have a particular developmental disability, but what I'm experiencing is depression, which is a behavioral health issue, right? What I'm experiencing is anxiety, which may or may not be a symptom of my developmental disability, but it needs treatment through behavioral health needs. I think sometimes we get confused, or we might get offered a service or a support through regional center that may not necessarily hit the mark exactly when trying to do some intervention. Okay.
Yeah, David, Jody is saying, I can't agree more. I work for a youth mental health provider, and communication between the two systems needs to improve.
Great to hear, Jody. Thank you so much. So, behavioral health needs for people with intellectual and developmental disabilities. There is no magic pill or there's nothing magic about it. A person with a developmental disability is as likely to have the full range of behavioral health needs as those who do not have developmental disabilities. There's nothing that says that a person with a developmental disability cannot have behavioral health needs. So this is a little bit of some things to think about as you are working with special ed services and your child is in high school. Remember, behavioral health or mental illness begins to appear early as a person becomes an adult. So schizophrenia, bipolar disorder, they can manifest themselves at around the age of 18 all the way through your 20s or maybe into your adult life. There are early indicators for psychosis, delusions, social withdrawal, a change in your mood or affect. The thinking becomes disorganized. Now you can imagine for a person with a developmental disability, spotting a delusion might be very difficult, particularly that person with a developmental disability uses maybe imaginary friends or imaginary relationships to help understand and cope with their environment. So a good indicator is the indicator. So when assessing for perhaps an early indicator for behavioral health, are the things that are happening contributing to an improved life, or making the life, or is the life in decline? Is the person's affect in decline? If the person is in a situation where things are getting worse, you might want to say to yourself, I wonder if this is an early indicator for some sort of psychiatric or behavioral health need. Another concern is bipolar disorder. Though these are the two, of course, psychosis, schizophrenia, and bipolar disorder are very difficult to deal with and manage, and are of course very concerning. Bipolar, particularly, you'll see a change in affect, either a very, very upbeat. That's the old manic that episode of manic, or you'll see a change in sleep patterns. Either less sleep is needed or more sleep is needed. Change in activity level, change in appetite, change in memory or concentration. So these are just, if you start seeing these things, kind of keep an awareness up, and if the situation requires attention, that might be the call to your service coordinator to say, I think I'd like to have an assessment, a behavioral health assessment. I think I'd like to maybe find out if California START services would be something my child can benefit from. Now, trauma and anxiety. It's earlier I gave that message about trauma, about the range of people experiencing co-occurrence of behavioral health needs for people with intellectual disability being as high as 70%. Well, the reason that it might be that high is trauma and anxiety. Trauma particularly has a big impact on our community, particularly the bullying that occurs at schools. Often I work with people with developmental disability, and the first thing they talk to me is about their special ed experience and the problems they had with bullying. It's a problem. It needs improvement. We definitely want to support and activate any anti-bullying campaigns. We must insist that schools apply their trauma, their bullying programs and protocols to make sure that people with special education do not get bullied, and that those who do the bullying are receive the appropriate discipline. Darcy, I know you have some thoughts about this. Do you want to share?
Yeah. So for me, actually, when I was a kid, I actually was bullied quite a bit. And thankfully, I had a wonderful principal that said, you know, Darcy, what do you think would be an appropriate punishment? And I said, well, I think that these boys should be allowed to take notes for me for the rest of the school year. And so that's what they did. And to this day, I am still friends with these boys. They are now special education teachers themselves. So
Wow.
My principal took a bad situation and totally changed their outlook, my outlook. So there are different ways that people can address the situation.
That's a fantastic story, Darcy. I'm going to steal that story from now on, if you don't mind.
That would be fine.
That's great. So Darcy's a great advocate. You can see she's going to be a fantastic clinician. She's just wonderful. So thank you, Darcy. Really appreciate that. The other thing is anxiety, and I'm going to talk a lot about anxiety now. And feel free to, again, raise your hand or ask questions and that sort of thing. Now, I am a licensed marriage and family therapist, and I do not have a practice, but I do pay particular attention to anxiety because I believe it is perhaps the #1 issue that needs attention when people are seeking treatment. Particularly for people with intellectual and developmental disabilities, I think anxiety is something that needs to be very well managed. We should all become experts in what I've heard termed mental health first aid, but we all need to become experts in knowing what anxiety is and knowing how to manage anxiety. So this is a chart that I've stolen from the internet, and I'm going to use it to kind of explain my opinion about anxiety. And let me get my highlighter out here. I'll do my laser pointer. So if I were to ask everybody, how are you doing today? Darcy, how are you doing today? What's your go-to answer?
I'm good.
I'm good. We like to say we're good. And we are programmed as human beings to say we are good.
We're wired that way.
Yeah, we're all wired that way. That is our set point. That would be this little blue line here. This is I'm okay, I'm doing okay, I'm good. And we're at this little in-between state of being in a good mood, a happy mood. We're wanting to socialize with other people. We're wanting to get to work.
Of course, we're always a little worried. We're always a little anxious. We got to be at work on time. We got to make sure we get this project done. There's a deadline to meet. And that creates a little bit of anxiety. That's okay. That's human beings. That's our homeostatic point. Okay. This is true for all human beings, whether you have a disability or not. This is true for cells. This is true for little one-celled organisms. We are wired to be homeostatic. Okay, now, there are times where we experience triggering events that cause our anxiety to go up, and it goes up in a particular order. And I think you're all familiar with the terms fight, flight, and freeze. And I want to kind of go into this in a little bit more detail. These are normal human responses, and these responses are designed for human beings to feel safe. We are triggered when we feel unsafe, and we are going to respond to it in one of three ways: fight, flight, or freeze. Now, what happens when we have this fight is there's a whole triggering system within both our nervous system and within our brains, our neurobiology, where there are neurochemicals released that activate our system to respond. Primarily, there's the limbic system, your emotional response system, that identifies an unsafe situation, calls the body into action, releases a neurochemical called cortisol, and our body is set into action. Okay. Now, the flight and fight, I'm going to go a little bit more into that. Well, before I go into that, I'm going to create a new slide here. Let's see this slide here. So this curve is way too generous. It gives this impression that things go smoothly up and things go smoothly down. And as you know, if you're a person prone to anxiety, nothing goes smoothly up or down. It's much more complicated than that. Particularly triggering events. Triggering events don't slowly go up. When you're triggered, it's an immediate response. It could be in less than a second that you go from everything's fine to I'm ready to go into a full-on rage. This triggering event is rapid, and it's complicated, because if it's so rapid, how can you prevent the behaviors from emerging? It's important to be aware of that. And the reason this triggering event occurs is because of that limbic system saying you are in an unsafe situation, you need to respond. If a car is barreling down the street while you're in the crosswalk, you need to get out of the way. You don't have time to think about it. So that is what the body does. It releases that neurochemical cortisol and it shoots you into action. Now, once that neurochemical is in your system, it's in your blood system, it's doing its work of helping you respond to the fear, but it takes a while for it to go away. You have to kind of get past the emergency event, and then the cortisol has to get through your blood system, make its way through the liver, wash itself out, make its way through the liver again, wash itself out. So to get off of the cortisol, to get your mood back to the homeostatic place, takes time. The blood flow through your body can be anywhere from 20 to 40 minutes. So you're really not going to see any improvement from this situation until you're calmed down. It's going to be at least 20 minutes before you're getting back to the homeostatic place. That 20 minutes or that 40 minutes is important to understand, because when you are in an anxious state, a fight, flight, or freeze state, you are not going to be able to be cared for. You can't reason at this point. Your body is only responding to the threat and only trying to get out of, to return to safety. Does this make sense? Any questions? Darcy, is this what they're teaching you in school? Darcy?
Yeah.
Okay,
Yes.
good. All right. So as I said, this is human nature. It's our human nature to keep safe, but this response system can be counterproductive. Also, I want us to be careful with these words, fight, flight, or freeze, because they kind of have, they're somewhat metaphorical. Fight and flight is taking action. So fight would better be understood as you're taking action and you're going to confront the issue or the danger or the individual who's causing the trigger. It's confrontive. It's going to lead more toward conflict. It's going to lead more toward aggression. So the fight response is this approaching the person to have them stop whatever the thing they're doing that's causing the triggering event. The flight is also an active step, but it's more of an avoidance. You're going to get yourself away from the triggering event, and you're going to do. You might go into your room and slam the door. You might run out the door and head toward try to get away from the triggering event. Other ways human beings handle that is through detachment or through distraction. If I get real anxious or nervous, I need to get out of my thoughts, and I need to maybe distract myself through music or artwork or reading or watching a movie or reading a book. The freeze phase is problematic, and flight and freeze are very different. A freeze phase is a protection phase where you're actually needing, you can't get out of the fight, or you can't get out of the anxiety producing situation. So the body or the self needs to protect itself. And that is through this freeze response or shutting down, which most commonly is seen through becoming depressed or going into a depressive phase. Fight, flight, and freeze are human nature, but they can be counterproductive. And for us with children with developmental disabilities, for us with children, or for children themselves, we all know the counterproductive aspects of this response system to our anxiety. So there are points of intervention that I think are important to share. So the trigger, when the person is triggered, the intervention that needs to occur is to try to help the person improve their impulses. So that would be the treatment for triggers is improving impulse control. And of course, for children and for people with developmental disabilities, for some of us at least, impulse control is something that's difficult and needs treatment or needs to be managed. When you get into this fight or flight stage, you've got to figure out what to do when you're up at this level. Of course, conflict may not be the best thing to do. Running away may not be the best thing to do. So what is being encouraged when you're in this heightened state of anxiety, when you're in this flight or flight mode, is to take a conflict break, which is to bypass this upper portion of the curve and try to take, the old school timeout, where you're going to stop, get away from the event, detach yourself from the event, cool down, and get back to a place where you can start returning to your homeostatic state. This is a conflict timeout. It's sometimes called a timeout. It's a healthy detachment or a distraction. This is important. So with our children and with ourselves, we might want to say, excuse me, I'm really having a difficult time with this right now. Can I take a few minute break in order to collect myself before I work out this problem with you? This is something we encourage couples to do in marriage and family therapy. It's something an employee should do if really frustrated at work and needs to take a break before getting into conflict with supervisors or customers or that sort of thing.
This is also something that I do a lot on the crisis line.
This is what you're talking about, Darcy, when you were that 30 minutes, you said the 30 minutes, they're calmed down again because they've distracted, they're talking to you, the cortisol gets out of their system and they return to homeostasis, right? What we want to do during this timeout is avoid this line right here. This is if your response to stress includes this, and then you get stuck and you can't get back down to homeostasis, this occurs. Trauma induces this situation. But truly what's actually happening here is the person is stuck in rumination. They're ruminating about the problem. They can't stop thinking about it, or they can't stop reacting to it. It's like they're stuck in this fight flight stage, and it becomes a bit overwhelming and could lead into this depression state. So the idea behind this conflict break is to get the person out of their thoughts and into something healthy that will lead them to get their mind off the issue and cool down. We have to be careful with distractions. There are distractions that are positive, and there are distractions that are negative. A negative distraction would be maybe too much reliance on alcohol or drugs, too much reliance on video games, too much reliance on a particular set of behaviors that calm us down, but then become counterproductive because you don't stop that behavior. So you have healthy distractions and unhealthy distractions. Okay, so the skill to develop during this calm down phase, or this return to stasis phase, is you want to get back to self-regulation. You want to return to being and feeling safe. Okay, these are your calming strategies, your mindfulness practices to help you move back into stasis. And then treatment. The treatment is best offered when you're in this state, when you're in this okay, how are you doing today? I'm doing fine. That's when you want to get your treatment. So that's where you might decide to get counseling, where you might decide to work on your, so counseling would be under behavioral health services. This might be the area where you work on your skills, and that would be through developmental services. And what we're trying to do is have the person build resilience, or PERMA, which is they have positive emotions, positive relationships, they have a meaning to life, and they have meaningful activities. This PERMA, which is a behavioral health term, is very similar to what you might hear when talking about person-centered thinking or person-centered planning. So this is where you would actually do your work. Does this make sense? Does this help me? Let's see. Sheridan, type into chat with your go-to response being triggered. Yeah, that's a good one. So we have so Sheridan likes to fight. I would say Sheridan is good at confronting. Confronting in a positive way to help generate a good discussion. Any other thoughts about this role of anxiety? Do you see this having an impact on your child with a developmental disability? And Darcy, feel free to speak up at this point.
Okay, I think personally, anxiety, I remember a couple slides back when you said that people with disabilities are somewhere like could be about equal to someone that is not. I think that from my experience, people with developmental disabilities, I think it's higher that individuals with IDD and mental health needs do experience a greater need of anxiety, and it could be based on just their disability as well. So I think also that needs to be addressed with clinicians and with families, and helping families like navigate that. They might be anxious because they're experiencing more pain, because they're having more muscle spasms or whatever that can create more anxiety. And maybe someone's symptoms of anxiety, they're not necessarily the typical ones. So I think it's really important to really be an advocate for your child or for yourself as to maybe what you're experiencing. And often, like David was saying, mental health clinicians, they're like, oh, you have a disability, contact regional center. And it's like, yes, but I also experience anxiety, or I also have PTSD, or I also have whatever the case may be.
Thank you. Yeah, absolutely, Darcy. Absolutely.
And Darcy, this is Sheridan, something that I thought of that I wanted to emphasize that you brought up is that we know from lots of studies that people with IDD oftentimes have higher rates of trauma in their lives.
Yes.
And are often re-traumatized and are less likely than the general population to get mental health care after that trauma, which means we have more people in our community with PTSD that's been untreated, right?
And sometimes I believe the trauma could happen with a mental health provider because they just don't know. They just don't understand, and they're re-triggering the person, or even like with a physician, often they have no idea how to work with somebody with a disability, and they have good intentions, but they might re-traumatize someone. So I think more education needs to happen both on the mental health side as well as physicians and other disciplines caring for people with disabilities.
The person with a disability, if you're a clinician and you've gotten all this training and you don't know how to work with a person with a disability, well, guess what? That's a trigger, right? So that's anxiety. And one of the ways people handle anxiety is to maybe blame. So they'll put the blame on the person with a disability. Well, that person with a disability now just has been triggered, right? And they have little to handle. So it becomes this kind of crazy eight of anxiety leading to more anxiety, where the person with the disability is the one who's always going to experience the greatest level of anxiety. Yeah, so it's very interesting and it's very complicated.
It took me several years to find a mental health clinician that I could really work with. She had no idea of how to work with somebody with an intellectual disability, and she's a PhD.
Yeah, it's amazing. I want to talk a little bit. I kind of like just said, oh, what did I do here? Let me get here. I said, oh, this level here, when the this is kind of your crisis phase, all you got to do is handle impulse control. That's not fair. That's easier said than done, for sure. Impulses are really problematic for our community, and we want to I don't want to leave you stranded saying, well, what does he mean by, oh, it's just handling impulse control. So there really are a couple of ways to handle, to think about impulse control. One, for people with autism who are receiving applied behavioral analysis, they are learning how to control their impulses. So on the developmental side, we're utilizing, thank you, Sharon, I see that. We're utilizing ABA to handle impulse control. But on the behavioral health side, cognitive behavioral therapy is an intervention technique that is effective. And I just want to give a quick overview that the situation, the trigger, is going to lead to a series of thoughts and beliefs about what just happened. That's going to lead to consequences. This thought and belief will lead to feelings and behaviors that'll lead to consequences. So this is the situation leads to the trigger, the response to the trigger, which is going to be the emotion, which is going to be the fight, flight, or freeze. That's going to lead to the consequences. So what you need to do in a situation when you're at this level is break this interrelatedness. Change the thought or belief, change the feeling or behavior, or change the situation. When you can change one of these three, you can change the response to all the entire situation. So remember, the trigger leads to the person needing to get safe, leads to that person being fearful, leads to that person taking action, which leads to the consequences. So if we can break this cycle at one point, we're going to be able to reduce the anxiety or help the person get out of that stage. Oops, wrong button here. Apologies. And I know we're getting toward the end. We're really very close to wrapping up. Let me hit the right button here. So I use the term mental health first aid. one of the things we need to do to avoid anxiety is to build resilience. The term being used right now in today's world is wellness or mindfulness. These are the techniques used to help manage and control anxiety. These techniques are very applicable to people with developmental disability. We hope within your family system or within your school system or at the care home or the day services that our folks are, or at the school that our folks are going to, that wellness is being instructed. Here's a good list of them. And I highlighted breathing, because when you breathe, when you take that deep breath and that slow exhale, you're communicating to your limbic system. You're communicating to that cortisol that you do not need to be afraid. You do not need to be fearful. You can return to stasis. So breathing has a very important physical effect on controlling anxiety. So definitely do those short breaths. All right, I want to thank Sheridan. I want to thank Stella, and most importantly, I want to thank Darcy for her contribution. Darcy, your story about bullying was fantastic.
Thank you.
All right, everybody. Thank you all very much. Alyssa, thank you. Bye-bye, everybody.
Bye. Good night.
Good night. Thank you, Stella.
You're welcome.
Small turnout
Hey.
tonight.
Yeah, I'm surprised.
That's crazy. Was this helpful?
Yeah, you know, it's really funny. I'm going to be working with NAMI in Santa Cruz County.
Oh, fantastic.
They asked, I'm going to be interpreting for their speaker series, and they asked me, are you familiar with behavioral health terminology? And I said, well, as a matter of fact, I have been working a lot with behavioral health terminology. So see, everything happens for a reason, right? So.
Oh, good. We did have a couple of people answer
Oh, good.
in Spanish. So there was a couple listening.
All
So
right.
how do I share results? I share results. Oh, no, I don't stop sharing.
There's 6 people who answered.
Yeah. So I don't know how to stop sharing. How do I, oh, wait a minute. Download results. That's what I want to do.
Yeah. All right, dear.
Okay. Thank you,
I
Stella.
will see
Talk
you
to you later.
soon. Okay,
Bye.
take care. Bye.